The changes. The term mental retardation actually changed a while back for those of you who might work in schools. So do I have any social workers here that are school social workers? Okay. Those people in the schools have not been using the term mental retardation for several years. The changes here was consumer driven. A little girl named Rosa had Down syndrome, and many times children who are very challenged intellectually are not challenged emotionally. So this little girl knew that emotionally the term retardation was not a nice term, that it seemed to be, judgmental, pejorative. She didn't like it. She went to her parents, she complained about it, her parents went to the Supreme Court, and they asked that this not be used in the school system anymore, and a law was passed called Rose's Law. And I think that was in 2010, and they have to use, the public school system has to use intellectual disability. So now we do too. All right, so, and the reconceptualization, not just the name, but the reconceptualization is we should not base this diagnosis solely on IQ. That, we really should look at functioning. So this is based on functional ability and adaptive functioning in at least 3 domains. And the domains are the conceptual deficits, which we've always considered, but the social deficits, interpersonal communication skills, friendship, social judgment, empathy. And practical deficits. Are they able to take care of themselves? Personal care, organizing their school stuff for older people, work activities, money management, job duties. The severity rating is based on the level of support required, mild, moderate, or profound, and there are descriptions in DSM-5 for that. So an example, I see a little girl, and just after I read DSM-5 and read this area, she was referred to me. She's very challenged intellectually, and on a IQ test, she would definitely qualify. Here's what I didn't know. I had already known about higher social functioning. Very sensitive kid, high empathy. She's socially aware. She comes dressed very cute, cute little shoes, everything matches, everything's perfectly put together. I didn't know how much her mother worked to get her to that point. I later learned from the father that this little girl does not know how to tie shoes. She cannot wash her hair. The functional level was really profound support was needed for this gal. And so I think that's important. We're looking at the context again. And it helps us to know to ask those questions. For ADHD, there's been criteria changes there too. The 2 lists that are exactly the same are the hyperactive inattentive, hyperactive impulsive. That should say hyperactive impulsive and inattentive. They're basically unchanged. But the age required for the onset of symptoms, it used to be if you were making a diagnosis of ADHD, you had to find evidence of symptoms before the age of 7. Now, you only have to find them before the age of 12, which helps if there's a later onset of an issue. But it also helps for adults who come back. So anybody have an idea why it would be easier to see an adult and find out how their symptoms were if there was any stuff before the age of 12 versus the age of 7? I can get lost in a parking lot. I can park my car, go into a mall, and I can come out and think, oh no, where is my car? So if I think as an adult, or now as a senior citizen, if I go in to say to a therapist, I think I might have ADHD. Could you do a screening and, maybe I need some stimulants or something? That person under DSM-4TR would have had to ask me, so before the age of 7, Did people see you was running around like a motor? Did you bump into things? I don't know. If they asked me before the age of 12 about these symptoms, middle school. Middle school is usually a nightmare for an awful lot of people, and they do remember. So yeah, I would remember if people were making fun of me because I was driven like a motor or forgetting things or losing things, because people make fun of people and tease and bully in those age groups. I would remember. Okay, greater emphasis on identifying adults, lifespan approach, making the symptom descriptions more applicable to older adults and older teens, like forgetful and keeping appointments or returning calls. They made the symptom threshold lower. For 17 and older, you only need 5, not 6, for one type or the other. It's still 6 for children and younger teens. Symptom list the same. The cross-situational requirement, instead of it must be in 2 settings, greater than or equal to 2 settings. It's in the neurodevelopmental disorders to reflect some brain correlates, executive functioning issues. And you can make ADHD and autistic spectrum disorder comorbid. You can diagnose both, which I think is a great change, wonderful change. Because there have always been kids in the autistic spectrum who have very severe problems with inattention, and not just part of the autistic spectrum. And they should be treated separately, and that should be identified separately. The subtypes. This is a good change too, because the symptoms change. Hyperactivity changes in adolescence, and it becomes more of an internal restlessness. So people have always asked me, well, what do I do? This is a child who's already been diagnosed in childhood with ADHD combined type. He's been medicated for it, but I don't see any symptoms of hyperactivity now. Well, it's because it does change with age and developmental growth. So now you look at what's the presentation primarily within the last 6 months. Has it been predominantly inattentive or predominantly hyperactive, or what? They've added some criteria for partial remission, because sometimes they don't meet full criteria, but that's still evidence of impairment and it can go on a while. And then there are some severity ratings that have been added. Okay, everybody smiles in the same language. This is a new disorder. So as I'm reading this, I want you to think, before you look ahead, on, what does this sound like? What disorder do you already know that it sounds like? It's a new diagnosis. It's characterized by difficulty in social uses of verbal and nonverbal communication in the natural context. So greeting and sharing, they don't do that appropriately. Impairment in the ability to adjust communication to the needs of the listener or the context. Inside voice, outside voice, right? Difficulties following the rules of conversation, that you listen, somebody's finally done, you reciprocate after they ask you, how are you? And you blab on, then you say, and how are you, right? Difficulties impact development of social relationships that cannot be explained by low abilities in the areas of word structure and grammar. So far, what does this sound like? Yeah, it really does. However, there are no repetitive patterns or restricted interests. So it would not fit into the autistic spectrum, but it does, here's what it does. It replaces, remember they want to get rid of all the NOS? It replaces the PDD NOS. And there are associations, ADHD, behavior problems, learning disorders. And again, symptoms present in early childhood, may not be fully manifest until social demands exceed capabilities. So it really did sound a lot like Asperger's, except for the restricted interest issue. So here's the big one. Why did they do this? Why did they get rid of Asperger's? Like, no Asperger's? You gotta be kidding. But no Asperger's. The research, the task force was headed by Susan Sweeto. And if you don't know her work, she's really a good researcher, sound person. She's written a lot on the pandas. What she did with her group is see if autism was differentiated from what is considered normal developmental patterns and differentiated from the other disorders in DSM-5. And it clearly was. So autism kind of held a good ground. Then they tried to discriminate between autism and the other PDDs, and there wasn't reliable discrimination between them. It was primarily due to language level or IQ features, or sometimes some associated medical conditions. They then tried to differentiate among the other PDDs, and they couldn't. And some were, the childhood disintegrative disorder, there weren't even enough people diagnosing it to validate it as a diagnosis. So, in addition, they're trying to get rid of all the NOS, and part of the reason I think they want to get rid of the NOS is that if you look at treatment studies and you follow everything they say to do, and you think, oh great, this is very effective, and it doesn't work for you. And you think, what am I doing wrong? And you go back and you're trying to follow this stuff. You go back to the original research and you find that over half of the people in a lot of these studies had the NOS diagnosis. That's not the people we get. We get people with comorbidities. And you know, we don't get these simple little things. We get complex. So, you know, if we don't have the NOS, future research will be based on what we treat, comorbid conditions, and not the minimal symptom presentation. Okay, here was another kicker, and I didn't almost believe it until I went back. We never should have had the diagnosis. Technically, there never should have been an Asperger's diagnosis. If you go back and you look at DSM-4 and you read all the different descriptors, it says, in individuals with no language delay, there are marked impairment in the ability to initiate or sustain a conversation with others. Asperger's, right? But that was already defined as a symptom presentation of autistic disorder. Okay. So Asperger's is just part of the spectrum. It's gone. It's just autistic spectrum. And that would include specifiers of severity, verbal inabilities or abilities, or associated with some known causes or medical things, epilepsy, etc. The big deal about this is, okay, will my kids get accommodations? The Illinois lawyers got together with the advocacy group for autism, and a law was made and passed that children who already have accommodations in schools and they have this diagnosis of Asperger's, they will continue to get the accommodations. So somebody already in the system getting accommodations will continue. It doesn't speak to the families who think, oh, but I think my other child has Asperger's. Doesn't speak to that. And then there's a worry. Will my child actually fall into the autistic spectrum or not? Will they get accommodations? So that's a bit of a worry for parents. There's also stigma, and some parents don't want their child to be called autistic or autism spectrum. My child isn't in an autism spectrum. My child has autism, right? So, or Asperger's, excuse me. So it's the stigma kind of thing that's a concern. So then there's coverage, insurance coverage. And I don't know about you, but very many of the teens that I see, the parents want the most serious diagnosis because the child gets more, under the parity law, the child gets more sessions. And if the child has a more severe diagnosis, they should get more accommodations, right? Things should be covered. So I've had parents come up and say, please, can't you just diagnose them as having bipolar disorder? And I say, no, I can't just diagnose it. But gee, it would work well for you. You could have as many sessions in a year as you like rather than this 12 a year. Okay. So, I mean, that's, you know, those are the big issues. I don't know how some of this is going to play out. I don't. Okay, so what they did then is reduce to 2. Remember, for autism, there had to be, or a PDD, there had to be problems with communication, social relationships and repetitive interests or behaviors, stereotypies. They decided that it was too difficult to separate the emotional part of communication from the informational part. Like my job today is to impart information. But can you separate some emotional components? Are there no emotional components in anything that I'm saying today? Probably not, right? So how do you ferret that out? Well, what the DSM-5 task force said is, let's not even bother. It's too much of a problem. Let's make it social emotional communication. So there are two symptom domains. Okay. These are just more criteria all right, more stuff, and more specifiers. Here we go. The context again. The ratings based on the level of support they require to function. So here again, got to rate. Require support, substantial support, or very substantial support. That's really, really important. So we'll see how it all plays out. Oh, and that was supposed to be earlier.
Yeah. One of the symptoms of ADHD, of course, is that easily distracted, and I find myself looking at this as a face. As Susan was talking, those random thoughts that come wafting in. Okay, schizophrenia spectrum and other disorders. This is, okay, as we mentioned before, they talk about this as being in terms of spectrum. They start with the schizotypal personality disorder. The criteria are not listed here, but it is considered part of the schizophrenia spectrum. So the criteria are listed with the personality disorder. There's another section where they do that with antisocial personality disorder, that Susan will be talking about a little bit later. The big changes here, remember in DSM-4 they said that they required 2 criterion A symptoms unless one of the symptoms was a particular kind, what they used to call a Schneiderian first-rank symptoms, bizarre delusions, voices talking to each other, etc. They got rid of that special criterion or the special attribution, and what they say now, criterion A requires 2 symptoms, but at least one of them has to be a psychotic symptom. So at least one of the symptoms to diagnose schizophrenia has to be a delusion, hallucination, or disorganized speech, which I think is a good thing, because otherwise you end up with too much. If you have a negative, 2 negative symptoms or negative symptoms in a movement, then that starts overlapping with other conditions. But now it requires 2 symptoms, at least one as one of the 3 psychotic symptoms. Schizophrenia subtypes are eliminated, and the problem there, of course, was that they were too unstable. The subtypes changed over time. Now this is the one that's the big one, and this is the one that's going. How many of you work with people with psychotic disorders? Okay, how many of you have clients that are diagnosed with schizoaffective disorder? Okay, good luck. Here is what the changes in schizoaffective disorder. Under DSM-4, you notice it says schizoaffective disorder requires, there are 3 criteria. One of them is that the psychotic symptoms, the criterion A symptoms from schizophrenia, and the mood syndrome have to overlap. Number 2, there have to be 2 weeks of the criterion A symptoms in the absence of the mood syndrome. And number 3, the mood syndrome has to be present for a substantial portion of the current episode. Okay? So suppose that you have someone. So let's take a client that you have now, and let's say that this is total duration of the episode, and this is the duration of the mood episode. And suppose that you have someone that you're seeing now that currently has an episode of the condition that is 6 months long, and the mood episode has lasted for 4 months. Now, is 4 months a substantial portion of 6 months? Yeah. So, could they be diagnosed under DSM-4 with schizoaffective disorder? Yes. Okay. Now, suppose this person has had 2 other episodes. They had another 6-month episode, and the duration of the mood episode that time was 2 months, and then they had another episode that was 12 months long, and the duration of that episode, let's say, was also 2 months. So the total duration of the illness is 24 months, with a total duration of the mood episode of 8 months. Is 8 months a majority of the total duration? No. So they would not be diagnosed with schizoaffective disorder under DSM-5. Now I'm guessing that those of you who work with people with schizoaffective disorder are going to say, but wait a minute, wait a minute. This is a population that sometimes lacks insight. Sometimes the population is not a good, that sometimes the population are not good historians. How am I going to get this level of detail? DSM-5 is silent on that issue. This is one of the things, okay, when we were here last time, remember I'd said to you that I thought that the likelihood was that they were going to drop schizoaffective disorder from diagnoses from the section. They kept it, but they tightened up the criteria and, thank you very much, made it more difficult to diagnose. So because by the way that they did this, it's gonna make your life miserable. Now, here's what my prediction is. My guess is that probably sometime in the fairly near future, it may be a DSM-6, it may be DSM 5.4 or something, they will go ahead and drop this diagnosis because there have been problems with the diagnosis since day one. Number one, it's an unstable diagnosis. So that you have a person with diagnosed with bipolar disorder, and then they come in and are diagnosed with schizophrenia, and then they come in and are diagnosed with schizoaffective disorder, so it tends to move around over a period of several different episodes of the illness. So they kept it in, they tightened up the diagnostic criteria, and quite frankly made it harder to deal with. However, if your charts get audited, I mean, we know where this is going, right? So you have to be careful, and so that this is what's going to be required is to go back and get this, you know, from people who, like I said, are not good historians and often lack insight. And so, yeah, good luck. Now, the next other thing that they did that was a change is delusional disorder. They've eliminated the requirement that delusions be non-bizarre. Okay, now I think this is a good idea. Too hard to distinguish, right? I grew up in Eastern Oregon. I grew up on a rural area in Eastern Oregon, grew up on a farm. We, by God, knew the difference between bizarre and non-bizarre, and then I moved to California. So, they've gotten rid of the requirement that the delusions be non-bizarre. Differential diagnosis, one of the things that you remember for obsessive compulsive disorder, if the whatever it was that they were concerned about, the contamination, was held with delusional intensity, you made an additional diagnosis of OCD and delusional disorder. Under DSM-5, we don't do that. They have one of the specifiers lists the degree of insight, and I'll talk more about that in a little bit. So if a person with OCD or body dysmorphic disorder completely convinced that his or her OCD and BDD beliefs are true, then delusional disorder is not diagnosed in addition to OCD or BDD, okay? So that's a change. Criteria for catatonia, I suspect, is not a big thing. This is something that I would take very seriously because I think there's some real potential here. For all of the disorders in this grouping, all the psychotic disorders, they recommend that the practitioner rate severity of psychosis, or rate severity of dimensions of symptoms on the psychosis symptom severity measure. And then there are clusters. First of all, you rate the severity of psychotic symptoms, hallucinations, delusions, and disorganization. Rate severity of psychomotor symptoms, abnormal psychomotor behavior. Rate severity of negative symptoms, and they pick two that they're using to key on: restricted emotional expression and avolition, or inability to initiate goal-directed behavior. Rate severity of cognition, which I think is a good thing because this is one of the areas where impaired cognition, we haven't paid enough attention to this except in some situations. And this really came very clearly to my attention when we were working with long-term care facilities. Because one of the things I noticed about the people who were in long-term care versus people who were in the community didn't have to do with positive or negative symptoms or any of that other stuff. Primarily, the biggest difference was impaired cognition. people in long-term care that were there because they needed to be. And let's make that caveat. One of the biggest differences is that there was a lot more impaired cognition, which happens, not unusually in people with schizophrenia. Mood, then we rate the severity of depression and mania. Now, it does say that you may still make a diagnosis in this group even without the rating, but they recommend that you do have the rating. And here's what it looks like. Again, a 4-point or 5-point scale, hallucinations, and they pick the one that they use for the exemplar for hallucinations is auditory hallucinations. Delusions, there's 2 things you consider. One of them is the pressure to act and how much you're bothered by the delusions. Disorganized speech, abnormal psychomotor behavior, negative symptoms, impaired cognition, depression, mania. So, and these are the anchors that are provided. Where I think this is going is that my guess is that in a few years, first of all, if people do this and take it seriously. Now, we all know how the garbage in, garbage out goes. But if people make these ratings and take them seriously, my hunch is they'll probably go ahead and drop schizoaffective disorder, because how important is that diagnosis if we know that someone has, say, schizophrenia and a moderate level of depression or a moderate level of mania? We provided the same information without messing around with the diagnosis, because people can go back and forth on these different dimensions. The other thing that I think is potential, again, once we gather a lot of information and people are making these ratings over time and seeing how people change, it's conceivable that it might sharpen up our recommendations for treatment or at least level of care. Are there certain patterns of symptoms that would suggest that people would do better, say, in long-term care, or do better in a supported housing, or do better with one kind of treatment than another? So there's some potential for something good to come out of this, and one of the things I think probably will is getting rid of schizoaffective disorder. At dawn we ride! A little Valkyrie. Bipolar and related disorders. Bipolar 1, bipolar 2, cyclothymic. The biggest change is that mood disorders are split into 2 groups now. Remember, in DSM-4, we had one cluster called mood disorders that include both the bipolar disorders and depressive unipolar depression. They've split these apart, separated from depressive disorders, and placed them in between. The major changes in terms of specific to bipolar, criterion A for manic and hypomanic episodes now includes an emphasis on changes in activity and energy as well as mood. Remember, in the DSM-4, it said a distinct period of abnormally and persistently elevated, expansive, or irritable mood. The problem was, and I don't know how it was with you, but for me, the problem was if you're talking to someone who's been depressed for a long period of time, and you're asking them questions about mood, just not being depressed can sound an awful lot like hypomania. And so that was a little bit harder, and also family members found it a little bit harder to identify, especially in people with hypomania. So they've added this, and abnormally and persistently elevated goal-directed activity or energy. So there's now a behavior component that hopefully will make things a little bit easier. They got rid of mixed episode. Yes. I hated trying to explain this to people, to my students, because I always ended up sounding like Donnie and Marie, a little bit country, a little bit rock and roll, So they got rid of mixed episode, but what they did do is they kept the mixed idea in there as a mixed features specifier. So you can add this mixed features specifier to episodes of mania or hypomania if depressive features are present, or you can add it to episodes of depression when features of mania or hypomania are present. So if you have 3 or more symptoms from the other pole, so if you have mania or hypomania and you have 3 or more depressive symptoms, or with depression, if you have 3 or more symptoms of mania or hypomania, then you would add the specifier. Now, the reason that they did that, just briefly, probably where I'm guessing that this will be most important is where you have people with an episode of major depression who is what they talk about treatment-resistant depression. What sometimes happens is people with treatment-resistant depression who've never had an episode of mania or hypomania, what you may be dealing with is an underlying diathesis for bipolar disorder, but the person hasn't had one of those episodes. So that if you have the mixed features specifier, it may turn out that adding a little bit of a mood stabilizer or something to the treatment regimen may be useful. So my hunch is that that's probably one of the places we'll see this come up first. In terms of specifiers, they're kind of the usual list, but there are three that I want to point out. One is anxious distress, peripartum onset, and seasonal pattern. Anxious distress. When I was here last time, or when we were here last time, remember we were talking about one of the proposals was for a mixed anxiety depression, okay? That turned out not to fare very well in the field trials, so they didn't put that in the DSM at all. Instead, what they did was that they said, well, we're going to add an anxious distress specifier for people who have at least 2 anxiety symptoms during the majority of days of the current or most recent episode of mania, hypomania, or depression. And this is a list of the symptoms: feeling keyed up or tense. I want to draw your attention to this one: difficulty concentrating because of worry. People who are depressed have difficulty concentrating, but the difficulty usually sounds a lot more like, it's almost like being frozen or stuck or slowed down, you know. It's just too many choices and you kind of get overwhelmed. People with mania or hypomania may have difficulty concentrating, but it's because thinking is bouncing all over the place and they can't focus very well. This one is difficulty concentrating because of worry. Now, that may make it a little easier to distinguish between one of those others, but unfortunately, as we all know, our clients don't read the same books that we do. Otherwise, our job would be easier. But difficulty concentrating because of worry. So if we have 2 or more anxiety symptoms during the majority of days, we would add this anxious distress. High levels of anxiety associated with higher risk of suicide, longer duration, poor treatment response. You know, all things being equal, if a person has, let's say, major depression and high level of anxiety, the risk for suicide is higher. Severity, rating of severity of the anxieties based on number of anxiety symptoms from mild to severe. Peripartum onset. Here notice that there's a change in the name. And this was triggered by studies that looked at what we were calling postpartum onset. Over half of the episodes of postpartum onset actually begin before delivery. So that really, we've been dealing with peripartum onset all along. It didn't initiate after delivery, it actually started before. Now, one of the problems here, and everybody, all my colleagues that work in OB-GYN settings say that 4 weeks is not long enough. We should actually extend this longer. Why I think that they did that is that if you look at the changes, the biological changes in a woman's body after delivery, and you look at psychosocial things, the biggest set of changes that kind of decrease over time are the biological changes. Starts coming back to baseline. The reason I think that they kept this at 4 weeks is to kind of separate out a group where the issue is biology as opposed to psychosocial changes related to having a child in the home, not being able to sleep, for example. Any new parents here? Not being able to sleep, for example. So that probably what's going on here is really wanting to restrict it to biology. Whether that was a good decision or not, I can go either way. So it's now called peripartum onset. Seasonal pattern. Okay, for those of us who worked under DSM-3, remember, seasonal affective disorder used to be mania, hypomania, or depression, and then in DSM-4 they said, oh, never mind, it's just depression. Well, now they've said, never mind, and they've gone back to regular temporal relationship between manic, hypomanic, or depressive. So any of the 3 episodes. Doesn't include cases where there's an obvious psychosocial stressor, and of course the problem that we have in this hemisphere, seasonal onset of depression, of course, is about light. When is it that the light gets small, fewer hours of sunlight? During the time of all of the holidays. So how do you separate the light issue versus psychosocial issues having to do with holidays? The onset is probably not going to be as useful as Full remission is also at a characteristic time of the year. That probably, at least in the people I've seen where there was some of that going on, that tended to vary more than if it's about light. With light, it's within a kind of a fairly brief window. With psychosocial factors, it kind of spreads out a bit more. And the seasonal pattern is episode specific. So you could have somebody with seasonal pattern of depression but have mania or hypomanic episodes that occur at pretty much any time more randomly. So you could have its seasonal pattern is, again, is episode specific or syndrome specific. One of the things I would want to note about the peripartum depression, note that it says, I should go back here, it says if onset of mood symptoms. We've also seen people who have major depressive disorder when they get pregnant that the symptoms change, okay? They're talking about a situation where the onset of the symptoms are during or within 4 weeks of delivery, not people where there's a change during pregnancy, because that's pretty common. I don't even know how I got back to my crib last night. Who among us has not had one of those days? Depressive disorders. This is the list. Now, Susan's going to spend a fair amount of time on this one because this is a pretty important change. Disruptive mood dysregulation disorder, it's a new one. Persistent depressive disorder, I'll say a little bit about that. Premenstrual dysphoria disorder. This one's new. Persistent depressive disorder replaces dysthymic disorder and chronic major depression. Basically, you remember the problem here was if a person had both a chronic depression, 2 years or more rarely without symptoms, it started with dysthymia, then there was an episode of major depression, you would diagnose both dysthymic disorder and major depression. But if the chronic depression started with an episode of major depression, we would diagnose major depressive disorder chronic and wouldn't make an additional diagnosis of dysthymic disorder, and that made everybody's heads explode, okay? So what they did here was they combined the criteria and they got rid of that distinction. So it's persistent depressive disorder, and you would use that for both of these conditions. The symptoms list looks pretty much like dysthymia. Premenstrual dysphoria is moved into this group, and I'll say more about that. Mixed features, again, we can add that to episodes of depression as we talked about before. The bereavement exclusion. Okay, let's talk about this. In DSM-4, it stated that symptoms that begin within 2 months of loss of a loved one and do not persist beyond these 2 months are generally considered to result from bereavement, unquote, unless associated with functional impairment, etc., etc. Notice it did not say, and it has never said, major depression could not be diagnosed. There wasn't an exclusion. Okay, now let me show you why. How many of you in here have worked with an adult with major depressive disorder? Raise your hand. Okay, down. How many of you have worked with an adult with major depressive disorder where the episode was triggered by the death of a loved one? Raise your hand. That's the point. Okay, we've all seen people who've had episodes that were triggered by the death of a loved one. The other problem, of course, is that implied bereavement only lasts 2 months when duration is more commonly 1 to 2 years. It's a severe psychosocial stressor. The characteristics are pretty much the same. There is an extended discussion, and this again is one of those areas that Susan mentioned where they say use your clinical judgment, and there's an extended discussion against about differentiating between bereavement. And here, the decision to diagnose major depression requires clinical judgment based on the individual's history and the cultural norms for expression of distress in the context of loss. So there's an extended discussion. I kind of boiled it down into this graph so that this is about a page or page and a half in the DSM-5. But they talk about different areas where, in my opinion, where most of the action is in the pattern. Okay, it's probably more different than some of the others, or easier. In the case of grief, dysphoria for most people, you know, right after somebody dies, you're feeling pretty much continually sad most of the time. And then what a lot of people kind of experience is they, you know, a few weeks later, they notice, oh, I wasn't feeling sad right then. And they'll notice there's a kind of a time when they're not feeling so sad. And then the the grief part tends to come in waves that are associated with thoughts or reminders of the deceased person, and very often there's also the pain of grief is associated with positive emotions and humor. So there might be a kind of I'll see something that reminds me of my father, and then I'll feel sad, and then there'll be kind of a chuckle, and I'll think, you know, I think I know what my dad would have said about that. I had one of those experiences when they started selling bottled water. I can hear my dad so clearly. You paid $1.50 for a bottle of water? I mean, but that's pretty common. You know, you get that kind of, there's the grief and there's the chuckle at the same kind. Whereas with depression, more persistent, not tied to specific thoughts or preoccupations, and pervasive unhappiness and misery. There are some others, and you've got the table there. At first I was like, oh no, and then I was like, oh, that's all right. Have you seen this? If you're in, this is, do a YouTube search of mommy's nose is scary. What happens is they're filming the baby and mom sneezes, and the baby first reacts like, oh my God, mom's head's about to explode. And then, oh, mommy's just being funny. And she does it several times, and every time he goes, and then, oh, and laughs. It's really cute. Anyway.
So a little background on this new diagnosis I want to check. In about 2000, a lot of workshops came about to learn about pediatric bipolar disorder. How many went to those workshops? Anybody here? A couple of you did. And the idea was, so did I. And I began teaching this too, and then it was like, never mind. The idea that Barbara Geller came up with, she did some research and found a group of kids who, and when I say pediatric, you know, 5 to about 10 maybe, around those ages, who had rages, significant rages, whose cycling was different than the cycling of the typical bipolar disordered adolescent or adult, and their cycles were not, there was no discrete period in between. There were rapid, ultra rapid cycling, which sounded a little bit like a dishwashing thing, a very modern one, and there wasn't any recovery period. They were mixed episodes, and they were considered to just continue on. So we began teaching them, and I taught my graduate classes, and there were instruments designed for it, etc. What unfortunately happened as a result of that, so fast forward to the task force for DSM-5, they looked into the frequency or the increased frequency of the diagnosis of bipolar disorder in young children. It increased by 4,000%. So if you think about your knowledge of statistics, that's impossible. So way inflated. So there had to be kind of a look at that. There also were a lot of children then getting very heavy medication. Medication that was causing weight gain, drooling, skin issues, cognitive clouding, depression, more depression, leading to some of them committing suicide. So there were really harmful effects of some of these very serious medications given to young children. So closer look with the task force, what they discovered, they went back and they looked at Barbara Geller's research, and they found that she had not ever established an episode of hypomania or an episode of mania in the children that she had incorporated in her studies. So then what do we do? Well, we need to move away from this group of kids as being bipolar. And we need to find, what do we do with these kids that are throwing these temper tantrums and rages? And they came up with a new diagnosis called disruptive mood dysregulation disorder. And I've just said all of these things, but the parents who come in say, these kids, I gotta walk on eggshells. You know, they won't accept no for an answer, they're exploding, they're really difficult to deal with. And it sounded a lot like some of the kids with ADHD who get stuck on something. They're wanting that new video game, they really wanna go, it's Target tonight, and they're on the parent's case about it, and they just don't want to get off of it. It sounded similar. It may sound like some of the acting out kids with oppositional defiant or conduct disorder. So what was this if it wasn't bipolar? And I think the best way to look at it is this diagram that, you know, if the disruptive mood dysregulation disorder is pretty aggressive in their temper tantrums and rages, whereas ADHD is really not defined by aggression. It's not a characteristic symptom of ADHD. So while it looks a little bit like that, no, these kids are more aggressive with the disruptive mood dysregulation disorder. But with bipolar disorder, kind of looks, they're similar. But the difference is that the bipolar episodes, they occur in episodes. So there are periods of time on and periods of time off with the symptoms. The disruptive mood dysregulation disorder was more continuous. The kids with disruptive behavior disorders, you know, I don't see them so much as labile, because this group is the disruptive mood dysregulation disorder, very labile, very reactive. Kids with disruptive behavior disorders have a goal. The kids with oppositional defiant really want to wear down the parents or teachers so they have control over what they get to do. So they argue until the adult is just tired of it and gives in. So they got more power. So the next time they're pushing harder. Okay. The kids with conduct disorder, it's a totally different thing. Usually along the line, they have misread cues. They think you have been offensive with something. You've done something to offend them because they don't read cues well. They are anticipating bad treatment because many times they've had bad treatment, not always. And they're in the trenches waiting to get you. They're waiting. You know, they're waiting. They have a goal. And it's when are they going to stick it to you, okay? It's very controlled, planned, controlled. And when they do, boom, then you know, oh, God, I've been had, right? Okay, but that's not labile. That's planned. So this is what they came up with the criteria: recurrent severe temper outbursts, verbal and or behavioral. They need to be inappropriate developmentally. So a 10-year-old, for example, would not go into a store with all those people around, lie down on the ground, kicking, screaming. No. A 5-year-old, yeah, but a 10-year-old, no. So developmentally inappropriate. Frequency of the outburst needs to be 3 or more times a week, and these parents are coming in with at least that. Their duration is a year with no more, at least a year, by the way, with no more than 3 months symptom-free. Outbursts need to be present in at least 2 settings, severe in at least one. Here, the child has to be at least 6 because developmentally, under 6, they have temper tantrums. It's normative. Can't be any older than 18, so that's sort of the good news. It's going to morph. It's going to change. That's the good news. It's not going to continue forever. Maybe. Maybe, right? It has to onset before the age of 10. Criteria would never have been met for a manic episode or hypomanic episode. The mood, here's the difference. The mood between the outbursts is consistently irritable or angry most of the day, and it's observable by others. So it's really more of a unipolar mood, and the trajectory is either an anxiety disorder and or a unipolar mood disorder. So the maybe is correct. So the good news is you're not going to have those temper tantrums all the time, but you're going to have a child with another disorder, right? It may be a little less taxing, hopefully. I don't know, however, here's the question. I don't know if this is really going to change the potentially harmful medication. That's what everybody asks. They say, well, if they've designed this new diagnosis and this is supposed to get rid of the problem with potentially harmful medication, if you have a parent coming to you over and over again and says, wouldn't medication help this child? And they're saying, please relieve me, relieve me. They're going to find a doctor somewhere, and you know, the doctor may say, okay, let's try this. And yeah, Risperdal is going to calm it down, sure, but it create other issues. Yeah, Abilify, yeah. Exclusion criteria, it couldn't be occurring specifically during an episode of major depression, or it would be major depression. Some other mental disorders look a lot like that at specific times. A child with PTSD can look like they're having lots of raging episodes of temper. Autistic spectrum disorder can look that way at times. Separation anxiety disorder, when they're pushed into something they don't want to do, they're raging and they're temper tantruming. Or a persistent depressive disorder, the old Islamic, or if there's substance medication. You would not diagnose it then with oppositional defiant, intermittent explosive, or bipolar. The bipolar would trump the disruptive mood dysregulation disorder, but the disruptive mood dysregulation disorder would trump oppositional defiant and intermittent explosive disorder, but it would never trump conduct disorder. We always separately diagnose conduct disorder in addition to, because of the potential harm. Okay, now bring me another Smurf. And I think we're going into eating disorders, I suspect. No, we're not. Okay. This was a disappointment among the many disappointments in DSM-5 and the many joys. I'm happy with it for many, many reasons. Non-suicidal self-injury. You know, they considered it, the task force considered it to be a disorder, and that was not really the right conceptualization. Kids and teens and adults will self-harm with a variety of different diagnoses. So a specifier was the next thing they thought. I expected it to be in DSM-5 as a specifier. It isn't. It's in Section 3. And it's one of those diagnoses for further investigation. I do think, however, I think that one of those electronic DSM 5.1, .2, .3, one of those supplements pretty soon, I really think this is going to be a specifier because there's such a rapid increase in the young people really self-injuring. Huge increase. And we really need to get early recognition. It's dangerous. There are infections. There are other things. And sometimes they have no intent to kill themselves, but they can either come close to it or they can, not meaning to. And then it can lead into where you have to be careful with this because there can eventually be the intent to kill oneself, to commit suicide. So you got to be careful. The task concerns here was they basically wanted to take self-injury to extract that from only the diagnosis of borderline personality disorder and just change that and make it consistent across disorders. And this would, real quickly, these are the criteria that you probably will see because they're in the appendix, I believe, that the individual would have on 5 or more days in a year. And for the young people I see in the UC, it's probably way more than that. Okay. They've engaged in the self-inflicted injury. They know they're going to produce bleeding, bruising, etc. A lot of embedding is not on this slide, but that seems to be a pretty heavy emphasis where they've actually cut open and they put something inside, usually a piece of metal, a nail, something where we can't see them injuring because they're injuring from the inside, but they're creating a lot of damage, and that's pretty darn scary. So we need to do something quickly. We assume that there's no suicidal intent by the method, if it's not lethal, or by the child's report that it is not an intended suicide. And we need to know that it gets addictive in the sense that the child anticipates, and teen, anticipates relief shortly before or during or after, or displays patterns of dependence. They're thinking about it even when they're not self-injuring. They're thinking it's there, it's there, it's there, and it's going to be realized. And it's associated with the same things that self-injury with adults would be, usually triggered by an interpersonal problem, something harmful, something they feel sensitive about, and they cut the pain out by, and the endorphins come out and enkephalins and all that stuff. So it's very difficult to control. The rest of it are just more criteria for it. The thing that is important, though, the behavior is not socially sanctioned. It's not part of body beautification, not part of the tattooing, not part of piercing. However, multiple piercing. If you have multiple piercing, that's often associated with self-injury. And there's a link between the self-injury and tattooing. They find something to help them. What I mean by that is, let's say you have a teenager who has been cutting on her arms and she's done the slash, that type of cutting, and she's got a lot of scars. And when she decides, I don't want to do this to myself anymore, maybe she'll go get a tattoo. Very beautiful tattoo that's like all tattoos. If whoever has a tattoo, there's a story behind it. I'm not going to ask you to all tell your stories of your tattoos, but there's a story. And the story behind that is, this was the day I decided not to cut anymore. So I'm not going to cut this too. It's too beautiful. My body, maybe I could cut on. I can't cut on this scar. So they stop for a while, and there's a lot of similarity. There's wound, there's pain, there's self-care, just like an injury. So it's similar, but hopefully a healthier movement. Yet I don't know what they do when they run out of canvas, because I've had some teens who were terrible cutters who aren't cutting now, but they're doing so many tattoos that I don't know where they put it. Luckily, they're taller than I am and they have more canvas. But where do you put it eventually? So I don't know where this is going to morph into, but something. Okay, Stan.
Okay, persistent depressive disorder, I've talked about that already, I'll skip that one. Premenstrual dysphoric disorder. The big question here had to do with, is this more properly considered a psychiatric disorder or a gynecological condition? And this was, you may remember, this went in actually DSM-3, so it's been in that conditions for further study now for 30 years. I finally moved it out and moved it into the Section 2. And the criteria are, in the majority of menstrual cycles, 5 or more symptoms must be present in the final week. Now here's the key, start to improve within a few days after the start of menses, and this is the big one, become minimal or absent in the week post-menses. Now this helps to distinguish between women who have an episode of major depression and severity fluctuates with the period. This becomes minimal or absent in the week post-menses. Here are the symptoms here. One of the things I want to point out, if someone comes in to see you and based on history, it sounds like they've got the real McCoy, they meet criteria for premenstrual dysphoric disorder, you would make the diagnosis, but it's considered provisional. So you have a provisional diagnosis until you gather 2 months of prospective symptom rating. So you give the woman a chart to track her menstrual cycle and track mood, track symptoms. And the question is, does it match, and does prospective rating? Because doing on history, our people, tune that carefully to when the onset and offset of the symptoms is. So until you get the 2 months, it stays provisional. And then you go ahead and make it a regular diagnosis. Specifiers, same ones as before, anxious distress. Oh God, I left the Easy Bake Oven on. Okay. Anxiety disorders. Okay. The disorders in the anxiety disorder group, separation anxiety, selective mutism, specific phobia, social anxiety, panic, etc. Panic attack specifier, agoraphobia, GAD. The big changes here is that they split the DSM-4 anxiety disorder group into 3 clusters. One of the clusters is anxiety disorders, which are the fear-based and avoidance behavioral disturbance kinds of clusters. Then there's the obsessive compulsive and related disorder group, and then there's the trauma and stressor related group. This was one of the few decisions in DSM-5 that actually biology did influence the decision-making process. If you do brain imaging studies of people with fear-based anxiety disorders and compare those with the obsessive-compulsive and related studies, you see different parts of the brain light up, okay? So that there's actually some neurobiology that went into the decision to split those apart. This one is the only cluster that the cluster or the grouping is based on precipitants as opposed to symptom pattern. We'll say more about that in a bit. So, Anxiety disorders differ from developmentally normative fear and anxiety by being excessive and persisting beyond the developmentally appropriate period. So it's pretty normative or pretty normal for, you know, a 4-year-old to be afraid of the dark. Well, not so much when you're 27. So they want to separate it from developmentally appropriate. Also, anxiety disorders differ from transient fear and anxiety, which are often stress-induced by being persistent, though the 6-month or more duration is a guide with some flexibility. So for the disorders now, they talk about typical duration is 6 months or more. So it isn't a hard criterion, but they don't want people, for instance, you know, transient fear, let's say you have an anaphylactic reaction to an injection, and so for a few weeks or a few months you're nervous about having a giving blood or getting a shot. What they want to talk about is something that's more severe and persistent than that. The other thing is that since people with anxiety disorders typically overestimate the danger in situations they fear or avoid, determination of excessive is made by the clinician considering cultural factors. And again, these are disorders where there's an extended discussion of culture. So this is one of those, you know, use your clinical judgment places where is that fear excessive or unreasonable? Many disorders develop in childhood and persist if not successfully treated. Separation anxiety, selective mutism are moved into this, and Susan will talk about that in a minute. Panic disorder and agoraphobia are uncoupled. Remember in DSM-4 we had pure panic disorder, panic with agoraphobia, and agoraphobia without a history of panic. These are now diagnosed separately, and what they did was they expanded the criteria for panic disorder. And so they added some of the symptoms that used to be in agoraphobia, and they tightened up the diagnosis of agoraphobia. So panic attack requires 1 month of either persistent worry about an additional attack or significant maladaptive change in behavior. And this is a part that comes from the old agoraphobia criteria. Significant maladaptive change in behavior related to attacks. For example, designed to avoid having another attack, like avoiding exercise or unfamiliar situations. So the kind of global situations that people avoid, like I don't go to the health club anymore, and you've heard the story that I go to the health club, when I exercise my heart rate goes up and I think, oh my God, I'm having a panic attack, and of course that thought then triggers the panic attack and it actually happens. So that kind of avoidance would now be part of the diagnosis of panic disorder. So essential features are unchanged. The types are changed. So instead of having situationally bound or cued, situationally predisposed and unexpected, they're either expected or unexpected. So for example, the unexpected, it kind of happens out of the blue. There was no indication, unfamiliar, you know, I've never had this before, might even wake someone up. By the way, in DSM-5, they have kind of an extended discussion about nocturnal panic attacks. So those that might be unexpected as opposed to the expected kind, so that, like for example, I have a fear of heights, okay? And if we go up to the top of the Sears Tower, I mean seriously, Willis, what's he ever done? Anyway, if I go up the top of the Sears Tower and we go out onto that glass deck, you got me blindfolded, we go out onto the glass deck and you whip the blindfold off and I go, oh my God! Okay, I will have a panic attack. I'll tell you that right off. Now, would I expect that? Yes, I have a fear of heights. So that would be an expected panic attack. So if you have a phobia of a bird and you walk in the room and there's something flying around, you're going to have a panic reaction? Yeah, okay, that's expected. Panic attacks can occur in the context of any mental disorder and some medical conditions. Panic attacks act as a marker or prognostic factor. So again, if you have someone with major depression, all things being equal, if that person also has panic attacks, they might be at higher risk for committing suicide. So we can add panic attack as a specifier to other DSM-5 disorders. You can add it to anxiety disorders, so we can have agoraphobia with panic attack specifiers. We can have depressive disorder with panic attacks, bipolar disorder, eating disorder, OCD, psychotic disorders. So we can add that specifier to other DSM-5 disorders. And again, the person doesn't have to meet the full criteria for panic disorder. If they meet the full criteria for panic disorder, we add that as a separate diagnosis. But if they just have panic attacks in the context of one of these other conditions, you can add that as a specifier. Again, no longer require recognition anxieties excessive or unreasonable. Situations avoided, endured with intense fear. All ages, note a typical duration of at least 6 months. And here's the criteria for agoraphobia. Notice how this is tightened up. Agoraphobia requires fears of 2 or more of the following situations: open spaces, public transportation, enclosed spaces, standing in line or being in a crowd or being outside of home. So they've tightened up the diagnostic criteria for agoraphobia, and then they pulled some of the more general avoiding situations where you might experience panic-like symptoms or that might trigger an attack. That's been added to panic disorder. Social anxiety, delete the generalized type and add performance only. In other words, that's a stage fright type, so that's performance only. Social anxiety. Separation anxiety.
There's not a whole lot to say about separation anxiety disorder. Conceptually, I didn't think about that continuing as a lifelong disorder. DSM task force says yes, it does, that the attachment problems that somebody has, the insecure attachment with mom, just gets transferred. Sometimes onto a best friend in adolescence, and sometimes onto a spouse in adulthood. So it continues lifelong. The prevalence is about half in adults as it is in kids. It just, needs to be 6 months for an adult to make the diagnosis, 4 weeks for a kid. And is there something else? And I've already talked about functional consequences related to age, right? The next one that I'd want to talk about is really selective mutism. So how many people have seen people with selective mutism? Okay, so you know that a lot of the symptoms were so much like social anxiety, difficulty using the bathroom at school, they wouldn't talk in class, would cover their faces if they're having strong emotions, if they started to laugh. It's social anxiety. And so that's what they're saying, is that selective mutism is a kind of an early representation of social anxiety, and that's what it will morph into over time. And that the situations where they don't speak in is not just, at home they speak where they're familiar and at school they don't. It's in social situations they don't speak. So it's changed in that way. Those are the important changes.
Okay, next group is OCD. Obsessive compulsive and related disorders, and we have obsessive compulsive disorder, body dysmorphic, hoarding disorders, a new one. Trichotillomania was moved over. These two, body dysmorphic and trichotillomania, moved into this group. Excoriation or skin picking disorders, a new one. They're again separated from other anxiety, the fear-based anxiety disorders. Body dysmorphic disorder was moved into this group from the somatoform disorder cluster. Let's talk about specifiers. Again, the insight specifiers reflect the full range of insight from good or fair to poor to absent insight and delusional beliefs. So we put the whole thing down, don't make the additional diagnosis of delusional disorder. With muscle dysphoria as a specifier that's added for body dysmorphic disorder. These are the people that feel that they're insufficiently muscular, and it doesn't matter, of course, what they look like. They can have, just be a mound of muscle, can't put their hands down at their side, but they can still have muscle dysmorphia. With excessive acquisition for hoarding disorder, the issue is persistent difficulty discarding or parting with possessions regardless of their actual value. People have excessive acquisition, they go out and acquire more. Okay, all people with hoarding disorder don't necessarily do that. One of the changes that was not made that I think they should have done, I think they should have either had a specifier or a separate diagnosis for animal hoarding. Because animal hoarders, you've really got a different phenomena going on. The treatment is different. The kind of fear is different. The person with animal hoarding, they're afraid the animal is going to be euthanized. And in fact, there used to be states, I believe Utah was one of them, that said if you remove animals from a person who hoards, if the animal can be saved, it won't be euthanized. Okay, so they kind of took that out of the equation, though I suspect it probably wouldn't do any good. Persistent, again, oh, and this is another place where there's an extended discussion. There's an extended discussion in there between hoarding and collecting. I think the differential is easy. If it's your stuff, it's hoarding. If it's my stuff, it's collecting, right? This is not so hard. What's the problem? So anyway, difficulty discarding possessions results in accumulation of possessions that congest and clutter the active living areas, substantially compromises intended use. If the areas are uncluttered only because of intervention of third parties, how many of you have been involved in decluttering? Yeah, I mean, that's not an unusual kind of an activity for family members sometimes or case managers to do. Clinically significant distress or impairment, and this is one I suspect that comes up for you, including maintaining a safe environment for self and others. Have you had any kids that were removed from a home because of hoarding? Yeah, that often occurs. That's one of the things that often occurs with animal hoarding, if there's children in the home, because, you know, health department is called in and kids then may be removed. So that's hoarding disorder. Body dysmorphic disorder, preoccupation with one or more perceived deficits. At some point, the individuals performed repetitive behaviors, for example, mirror checking. Now, let me distinguish the mirror checking. Okay, I see you guys laughing. You probably know people that can't walk by a mirror without checking. Oh, looking good today, Stan. Yes, sir, buddy. That narcissistic mirror checking is not what happens in a body dysmorphic disorder. With body dysmorphic disorder is, oh my God, is that bump on my nose growing? Is there something that's wrong? My nose doesn't look like his. There's something wrong with mine. So that comparison, or is there something that's changing, or is that scar whiter than it used to be, or is the mole growing? I mean, it's all of that kind of stuff. That's what's the mirror checking that they're talking about, not the narcissistic kind. Okay, oh, and not better explained by concerns with body fat or weight. So this helps to distinguish it from eating disorders. How do I put this? You will never sleep in again. I suspect that that's funnier to some of you than others. Trauma and stressor-related disorders. This is, again, the only grouping that is based on precipitants rather than symptoms. And by the way, I think we'll do this one and then we'll take a really short break after that. Reactive attachments, disinhibited social engagement, PTSD, acute stress, adjustment disorders are now here. Major changes. Now, when they were making the proposals, this is before 1994 when DSM-4 came out, there was actually a proposal to have a group that looked just like this. And they ended up deciding not to do it because they said, look, a lot of disorders are precipitated by aversive life events, by psychosocial stressors. People have episodes of depression that are triggered by getting fired from a job. People end up having episodes of anxiety problems because of something that happens at the hospital. I mean, people who end up have a surgery sometime will develop a kind of a situational OCD around that's related to care for the wound. So this is not unusual. How do we distinguish from these? Well, they revisited that question for DSM-5, and what they say is that there's a wide range of reactions to trauma and stress. And by the way, if you read some of the discussion around this, you can see that this was pretty heavily influenced by 9/11 and by the Iraq-Afghanistan conflict, by the military conflict, and by sexual trauma. So they say there's a wide range of reactions to trauma and stress. Sometimes these responses can in fact be understood in the context of anxiety and fear. For other people, however, the most prominent symptoms are anhedonic and dysphoria. It looks a lot more like depression. Externalizing angry or aggressive, kind of acting out behavior, losing control, taking a lot of risks. Dissociative symptoms is pretty common, and externalizing, or some combination, either with or without anxiety and fear. So they said because of this range of reactions to trauma and stress, these disorders are placed in their own group based on precipitants rather than symptoms. RAD and disinhibited social engagement moved over here. Adjustment disorders were moved. There's a different set of PTS criteria for children under 6 and under I should say. Sexual violence is specifically included as a trauma exemplar. Now it wasn't listed in there. They talk about death or serious physical injury. They now add sexual violence. They changed the symptom cluster. So here's what the definition of trauma looks like now. Exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. Directly experiencing or witnessing in person. Those are the same as they were in DSM-4. This is a new one. Learning that the traumatic event occurred to a close family member or close friend. In cases of actual or threatened death, the events must have been violent or accidental. Learning that a family member or close friend has a terminal illness wouldn't meet the criteria for trauma. Learning that they had been in a hurricane, or learning that they had been in a terrorist incident or were injured in battle, that would meet the criteria for trauma under this third one. But again, a terminal illness wouldn't. And this is another new one. Experiencing repeat or extreme exposure to aversive details of the traumatic events. Now, they give 2 exemplars in there. One of them is first responders collecting body parts is one of the exemplars. Another one, police officers listening to graphic details of child abuse, child physical and sexual abuse. What I found interesting that they didn't include is like, yeah, us. Now, the way I read this definition, that would totally meet the criteria. So if you're working with survivors of trauma, if you're working with people who are survivors of torture, and you're hearing a lot about those, that would meet this criteria, okay? There's a note that they have there. This criterion does not apply to exposure through electronic media, television, movies, or pictures unless the exposure is work-related. So for example, when the police officers, after the Boston Marathon bombing, they were looking at the closed-circuit TV feeds and looking for suspects and looking for clues and all that, and going over and over and over that would meet the criteria. The people after 9/11 that just left the television on and wouldn't turn it off, that wouldn't meet the criteria. The assumption is if you're just sitting there at home watching it, you can turn the damn television off. Okay? But if it's part of your job, you're kind of stuck there unless you quit the job. So that one is, this is one of the caveats that they have through exposure through electronic media.
What about required watching for the students for class?
Well, a single time, but it's repeated exposures, what they're through aversive details, experiencing repeated or extreme. Now, I'm guessing that if it's too graphic, that might meet the criteria. I'd be a little bit cautious because we don't want to overuse that as called too much stuff trauma. And by the way, I'm glad you asked that question. I should point out, they're talking about the initial exposure, because a lot of people who have been exposed to traumatic events get triggered and re-traumatized by something. That's not what they're talking about, the re-traumatized. That could happen. Remember when Saving Private Ryan came out? We had all the people who were developing symptoms of PTSD that hadn't had it before, okay, and it was triggering memories. That's not what they're talking about here. What they're talking about is the initial traumatic exposure to the traumatic event. Yeah?
Does the event must be violent or accidental apply to the experience? Like, we work with young children, so what if there was a parent illness and the child did witness the parent dying or
The parent dying? I don't think that would meet the criteria for the traumatic event.
Not according to DSM-5, in that there's a chronic illness that the child heard if this is a chronic illness. It wasn't a violent death.
or witnessed it and experienced
Yeah,
it.
witnessing the
Or
death.
unknown.
Yeah, witnessing the death or the illness. The way that they state it now wouldn't meet the criterion.
Would
Yeah.
it be a traumatic event? Yes.
Yeah.
Would it meet DSM-5 criteria for trauma?
Probably not.
Okay.
Yeah.
We often distinguish between those two types of trauma as trauma with a capital T, which is this one, and then trauma with a small t.
I like that. Yeah, trauma with a capital T, which is what they're defining here, and trauma with a small t, which is an extremely stressful event. Yeah, you know, I think that, I like that actually a bunch. I will steal that.
Okay.
Yeah, thank you.
I stole it too.
So here are the clusters, re-experiencing and intrusive symptoms. This is pretty much the same as it was in DSM-4, except you notice they've added dissociative reactions. Now, remember in the way DSM-4 was set up, PTSD, we often saw people with PTSD who had dissociative symptoms, but it wasn't part of the diagnostic criteria. So it didn't say that they couldn't have it, just wasn't part of the criteria. They've now added dissociative symptoms to the re-experiencing cluster. The avoidance symptoms, same as it was in DSM-4. This one they split apart one. Arousal and reactivity, this is expanded to include irritable, angry behavior, reckless, self-destructive behavior, along with the hypervigilance and startle. So they've added the kind of acting out in addition to the hypervigilance, startle, and sleep disturbance. This is another new one. Some of that dysphoric reaction has been changed. And so negative alterations in cognition and mood, inability to remember important. So dissociative amnesia is what they're talking about here. They're not talking about difficulty, inability to remember because of drugs. So a lot of people who've been exposed to traumatic events will kind of block out memories by drinking a lot or using drugs. That's not what they're talking about. They're talking about more like the dissociative amnesia. Negative beliefs and expectations, the world, you know, the kind of existential change in the way that you view the world and the things around you. So those are the 4 clusters. Specify either with or with dissociative symptoms. Delayed expression, note that. It doesn't say delayed onset. In my experience, the people I've seen with PTSD, it's pretty rare that someone doesn't have any symptoms at all and then all of a sudden has the symptoms of PTSD. What they say here is full criteria are not met for 6 or more months after the event. So there may be some symptoms, but the full criteria are not there, and that's delayed expression, and so they've changed that from delayed onset. Acute stress disorder, basically the same as it was before, 9 symptoms from 5 categories. Same definition of trauma. Criteria for children?
It's not that the criteria are so different, thank you. It's the wording and the reasons why we rejected the wording. The traumatic event, again, the children have to directly experience the traumatic event or witness it occurring to somebody else, excludes electronic media, unless the child, you mentioned a class, and if, for young children, if they are in a daycare center or they are in a kindergarten, pre-kindergarten setting, which a lot of children were, and you may have been around to have the same thing that I experienced with the children clients, is that when the planes hit the towers, a lot of kids were in their daycare or their preschool atmosphere, and the adults started turning on the television sets and left it on. Do you know how you get kind of mesmerized sometime by something, you know, traumatic and you can't move? So the adults did that rather than call the parents, turn off the televisions, call the parents and say, this just happened, you may have heard of it or not heard of it, especially with all of our electronic stuff now and our cell phones and our alert stuff. You know, that should have been done. And then the parents could decide how they were going to tell the kids. A rash of kids came in after that who were traumatized because they saw it all day long. But they were doing their job, weren't they? It was in their work setting, and they didn't have the opportunity to turn anything off. So if you find a situation like that, where there's electronic media that's part of their job, it still would qualify. All right. Learning about a trauma that occurred to a parent or a caregiver, it still has to be, though, that violent or accidental. The old terminology, reacting with intense fear, helplessness, or horror, how do you determine that in a young child? How do you determine if they're horrified? You don't. Plus, preschool kids, they're reacting to often the stimulation. They haven't the cognitive capacity yet to determine everything. Some kids are overbright. When they're traumatized, they're looking like they're moving around happily, just stimulated. So you can't say that they're, just because they don't look like they're intense and horrified, that they haven't been traumatized. It's a different thing. Traumatic reactivity, this was ridiculous in DSM-4. In children, traumatic reactivity may be expressed by disorganized or agitated behavior. Children under the age of 6? Come on, come on. What about this? Disorganized and agitated behavior. That's pretty standard developmental norm. All right. The presence of one or more intrusive symptoms. Well, the reenactment thing, it's just defined, instead of repetitive behavior, the main behavior they do is play. So it's play reenactment. The dissociative reactions, kids do have flashbacks, you know that. And you've probably seen the kids who are having visual, you know, putting their hands over their eyes, or they're having auditory stimulation associated with the trauma. They're blocking their ears. So that you can see that, or you can see a loss of awareness of the whole surroundings. Sometimes they, or a denial of, let's say an uncle was in this scenario, part of the traumatic event, didn't necessarily do anything to the child, but was there. That person often is not even recognized by the child. They don't want to look, they don't say hello, it's if they don't know him. Or sometimes the dissociative reaction of a child might be, that didn't happen to me, that happened to the other Desiree. They're doing some distancing, some dissociative stuff. So same thing, they do react with arousal to reminders of the event, or the trauma, etc., or external cues. And it might be an overbite reaction, but they do react. They lowered the symptom threshold, one symptom, from either persistent avoidance or negative alterations in mood and cognition. And they replace certain things, the addition of constriction of play to the marked diminished interest in or participation in significant activities. The significant activity they do is play. So constriction of play. Detachment or estrangement, too difficult in that age group. They just replace that with social withdrawal. Substantial increased frequency of negative emotional states and decreased frequency in positive emotional states. They anchored it, like increased temper tantrums that occurred after the trauma. Because they may have temper tantrums to a consistent degree before the trauma. So it has to be a marked difference from baseline. Increased arousal, blah, 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 blah. Same, okay. Distress or impairment. For these children, you have to pinpoint where the distress and impairment is. It has to be anchored, typically anchored in relationships with their peers, their parents, their caregivers, or, you know, at someone at school. So it's anchored for you to make this definition or this diagnosis in preschoolers. That's the same, just criterion, it's a month. Here's you can specify whether it's with dissociative symptoms of depersonalization or derealization, or with delayed expression. And here, this is something we know. Kids don't want to talk about it. Because for kids, if they talk about it, it's real. That's one thing. So delayed expression, really, I'm glad to hear that, to see that as a criteria. It'll become real if they talk about it. The other thing about talking about it with children is they might become vulnerable. How can they trust? If they tell someone how upset they are and how bad this experience was, then that other person will know how to get to them. So they don't want to tell. And a lot of the traumatization in this age group is in relationships with adults. So, yeah. I mean, it makes sense.
Say that again. What did you just say about adults?
Well, a lot of the trauma in kids that are preschoolers, the trauma occurs in relation to adults. A lot of it does. So, you know, why would you want to tell an adult where you're vulnerable if adults have harmed you, especially sometimes somebody in your own family? Yeah. It's really makes sense.
Could be physical or psychological harm.
Could be physical, could be psychological, could be something other, and we haven't uncovered the other yet, but that may be something that comes down the road. But if they talk about that, they're very vulnerable, or people may think less of them, or they may lose love. Yeah, yeah. Okay. Time for the break.
Yeah, time for the break. We're going to take a real short one, 5 minutes, and then we'll be back.